To the entire KFOG organizing team and the RCOG South Zone organizing team, a big thank you. Over the next few minutes, it's secondary postpartum hemorrhage uh, in a nutshell. So I'm just presenting a case which many of us have seen. She was referred to us on 10th post-cesarean section, 10 day 10, and brought completely wet, in a hemodynamic collapse state, absolutely. What do you mean by secondary PPH? Excessive vaginal bleeding occurring anytime after 24 hours up to 6 weeks postpartum, and it has been extended to 12 weeks postpartum and believed to occur in 0.4 to 1.4% of population. Now, in an emergency management, the maternal resuscitation is the same, and I'm not going to go through, we have been talking about it from beginning. Now, dealing with the cause, the algorithm is very different to the primary PPH. At this point, I would like to take a little time to say that severe triggers, in addition to the vitals and all, you have to have a different outlook for secondary PPH, because the woman experiences it at home, and it's a very subjective way of assessment, very difficult to quantify blood loss. Did she have fainting spells? How many doses of utrotonic? If she's had an intervention outside, you have no idea of how much blood loss has occurred. The lab tests in secondary PPH are similar, except that we add in beta HCG and a vaginal swab for culture. Sensitivity if the bleeding is not much. But step one of secondary PPH also is the same, resuscitation. And it's in addition of antibiotics. We use cefotaxime plus metronidazole, and if sepsis is suspected, we do add in amikacin or gentamicin at this step. The second step is you have to do a very rapid bedside ultrasound to know if the uterine cavity is empty or it's not empty. And the third step would be to use a Doppler to know what's your vascularity, not vascular, normal vascularity or very highly vascular. So with these three steps, I'm going to go into the etiology. Why does it occur? Secondary PPH, no matter what we say, no matter how well we train, it invariably, I think 80 to 90% of the cases comes into this part of it: retained placenta, endometritis, retained membranes. And if you have manual removal of placenta, the odds ratio of having a secondary PPH is about 4 times. If you have primary PPH, no matter what kind it is about 9 times. So many a times you do manual removal at cesarean section because we are a little impatient, and always the tick will be for completeness of the placenta and membranes, and the tick will be there. If you take a look at the risk factors, many a times you will find some of them will be there in retrospect of a case of secondary PPH. But one of the things that we all need to remember is that never push her into the theater or to do an intervention, okay, without doing a Doppler, without ruling out that that this is not adherent placenta. Vascularity, the site, amount of flow, correlation, using a 10 millimeter cutoff for the endometrial thickness was found to be the best part. Where does the role of MRI come into place? The MRI comes in when you have doubtful cases, when you have excessive vascularity, when you're suspecting that there is a bladder invasion or a parametrial extension. You want to know, before you attack or go inside and do a laparotomy. Now, moving to the second and the third causes, lower genital tract trauma and placenta accreta spectrum, they have been dealt with, and I'm not going to go through. But the most specific for secondary PPH is vascular abnormalities or the arteriovenous malformation. They are basically abnormal connections between arteries and veins, and then proliferation of this bunch of vessels, which leads you to think that it is just a very simple RPOC on a gray scale. But the minute you put a Doppler, you find that it is absolutely highly vascular, and you wouldn't like to touch it. The treatment as well as diagnosis is through angiography, and we can do a simultaneous uterine artery embolization. Now, the next one is choriocarcinoma, which has a characteristic appearance, but difficult to differentiate between invasive mole and an RPOC. Elevated, increasing HCG levels. We have to remember in a normal pregnancy, it goes down very fast. The cause that we should never forget is that coagulopathy. It can be acquired or it can be congenital, and something that for us to remember. But at the end, I would like to say that secondary PPH has a very rare, sometimes unexpected, sometimes mixed etiology. This is done by Kameshwari about a year ago, 16 weeks pregnancy and 2 months later, RPOC and an AVM. And Dr. Mamta had very nicely sketched it out and referred to us. We did a uterine artery embolization and then evacuation at a second step. So you can have anything, including a dehiscence of the uterine scar, including fetal bony tissue that has been. But okay, no matter what we do, we should send a histopathology. And in case if we suspect sepsis, culture sensitivity. I would like to conclude with an algorithm. The algorithm for resuscitation would be the same except a beta HCG being added. But over here, it would be a very direct stop. If the bleeding is torrential, hemodynamical and unstable, uterine artery embolization would be the first one. If you have a facility not available, tamponade, packing, transfer, not available, not controllable, hysterectomy. And if it is not severe or you are able to control the primary severe bleed, then you will have 3 steps. Imaging, Doppler, CT angio, or an MRI, and then vascularity either into absent or present, or it is very highly vascular. You will also do a beta HCG, high, low, present but low, but or a normal beta HCG. And you will come in the majority of the cases into 4 compartments: trophoblastic disease, or it might be a simple RPOC, or it might be an RPOC with vascularity, and it might be a polyp or a placenta accreta syndrome, or it would maybe an AVM. And I would like to end that the main difference between primary PPH and secondary PPH would be Doppler should be a part of secondary PPH algorithm. Thank you so much. I hope I've been in time.